Okay, guys. So I like to start, and I have taken your questions, and I think you guys are in. Any problem? Do you have any problem in listening to me? Atas, can you write me? Okay.
I can hear you, doctor.
Okay, great. Fine. So, guys, let's start the ball rolling. So, we have selected the question which has been sent to BLCs, and now I'll be taking each question one by one. So, let's start. So, the first question is, at your current level, what should we know about nose, pharynx, larynx, and trachea? In earlier, these concepts, out of them, the major chunk will be readdressed in year 2. So I'll take one by one. Nose, you need to know from the nose what are the conchas or turbinates and what opens under them. What is the blood supply? So these are the important concepts. And then nasopharynx, what structures are there in the nasopharynx and that stuff that you should be knowing. Coming from who are the structures who are living in the pharynx. Larynx, it's a very big topic, but you are expected to know the major muscles, their names only, and which nerve supplies them, and what are they used for. Very simple, very brief, short. And trachea, yes, for trachea you have to cover more things. So I'm sure I'm clear for this question. Is there any concern? Let me open the chat box. No, I can see. So we are clear. Okay, guys. So let's proceed. Now this question is saying, what do we know? What do we have to know about the posterior anterior view and anterior posterior views? So this question is regarding X-ray chest. So in X-ray chest, I'll try to explain to you in my coming slide. So now, when you are dealing, this topic has already been dealt with you in the structure of the week. So X-ray chest with Dr. Sadia. And usually what we use, what we do, and where you are expected to be good at the lateral view and PA view. And now in this PA view, I'll take one by one what you should look into each given X-ray. Your target should be assessment of the quality plus airway. So you can see that it's a good quality X-ray. Airway is clear because you can see the trachea. I'm moving my cursor here, and every structure is nicely visible. There is no extra shadowing, anything, and we can see all the things. So this is. Can you all see the bones very clearly? Where are the ribs, and is there any ambiguity with the ribs? Okay, see, cardiac shadow and size. You can see very clearly the right and left border of the heart, and look at, you can determine its size, that it is an enlarged heart or is a big heart or a small heart. Is it a cardiomegaly? And I'm sure everybody remembers we measure this distance and we measure this distance. The big distance will be minus from this if it's half. Cholet and the size. So we are good with that. Going further, diaphragm. You can all see the diaphragm is very nicely being shown, and there is no any extra. This is a PA, or we always, far as you will get PA view. PA. Okay? We always give you PA view. AP is very rarely done. Chest X-ray, when we do chest X-ray, nobody, because AP view is not giving us useful information which we are interested in. Only we get AP views when it's a real difficulty, when we cannot move the patient. So now, E for effusion, pleura. So where should I look for effusion? We all talk about costodiaphragmatic recesses. Costomedial standard recess, remember that is not visible on X-ray chest. For the costomedial standard recess, you should be using more of a CT scan. That will be more helpful. So when you're looking for the effusion, first target, because effusion doesn't mean it should be super full, maybe a small quantity. If this angle, focus at this angle is acute. If this angle goes obtuse, means it's filled up, so then we can say, oh, there is pleural effusion, right side, left side. How come in AP view the apex of the heart is at the left side? I think we should focus first on PA view. Then I park your question. We'll talk about that. Relax for that. So we look for E for effusion. Going further, fields, lung field. So you can look into the lung field, the bronchial margins and everything. Isa, I will answer you, relax for that. Then we should look for the great vessels. So you can see that the great vessel, you can see the aortic knuckle, and then you can see the mediastinal shadow. So there is nothing abnormally invisible. So this is how we can say that this X-ray is normal or abnormal. Then we should look at the hyla and the mediastinum. So hilum of the lung, you can see this bronchial shadows, and this is the mediastinal. If the heart is enlarged, what do I mean by saying mediastinum? If heart is enlarged, if there is any unusual addition, if it's more in size, there is some extra thing. So that is the mediastinum. So this whole line is mediastinum, because we all know in between the lungs we have mediastinum. So this mediastinum looks smooth to me. Going further, I for impression, overall assessment. So you can see overall this X-ray does not show any specific change which needs to be talked about. So this is a normal X-ray chest, and you should be looking at a PA view, posterior anterior view. Now, I'm bringing Isa for you. In this X-ray, there is a dextrocardia, right? Which X-ray? The one or before? This one? No, this is a normal X-ray chest. This side is the right side. This side is the left side. You were told.
Yeah, the picture is inverted.
No, the picture is real. This is a real picture. This is how an X-ray chest look like. This is the right field. This is the left field, because the apex of the heart should be on the left side. And we all know when we go into physics, I don't want to go into the physics. Simply remember this is a PA view. Now I'm answering your question where I'm showing you same person to same X-ray. One is PA view, one is AP view. Just see that. This X-ray of a person, this heart is looking to me a little bit big, and there is another X-ray of the same person. There is no difference between these two people. Look at the shadow of the heart here and look at the shadow of the heart here. Look at the amount of information and compare the fields. These are from the same person, X-ray A and B. This is X-ray chest PA view. On a PA view, it looks like that. And this is not a PA view of the same person, AP image of the same patient. So you can see that the whole distortion, like the images are not useful, and it's not giving me basically what I'm hunting at. I want to look at X-ray chest is giving me more info regarding my lungs and their lung fields. So there, this PA view is always used when we have to examine a chest, and a PA view along with a lateral view, and you can compare AP view with a PA view. And if you know this much is enough, because you are appearing a CVP exam designed for year 1. It's not a radiology exam. Okay, going further. Now, this question, how can we differentiate between a hemothorax and a chylothorax on an X-ray? So, for that, we need to look into an X-ray. First, let's bring an X-ray. Now, I'm showing you two X-rays here. They are in front of you. So now, these X-rays, where I'm putting my cursor, can you see my cursor? So what do you see in this X-ray? If you compare with the X-ray which I've seen before, pneumothorax. And what do you see on this X-ray? What do you see on this X-ray? Hemo. Now, thank you very much. I love you guys. You guys are mashallah smart. So now, this hemo, why we are saying hemo? Primarily, this is a fluid. It could be a effusion. It could be a chylothorax. It could be a hemothorax. So it could be any fluid containing, a fluid is present in my space. So that's why we call it. So now how I say it's hemo, because when I insert a small needle in that area for a diagnostic purposes. So I can aspirate. If I aspirate,
يا هلا وسهلا اخبارك؟
if I aspirate,
انا فتره والله موجود. الله يخليك، نور والله. الله يخليك يا رمان الله.
So When we aspirate the fluid out, which we can see on this X-ray, there is a fluid level, and this X-ray there is X-ray. This compare the sides. So this is the pneumothorax. This is a shrunken lung, and here we cannot see because all fluid level. This is a normal side. So now when we aspirate the fluid, when we take this little fluid out, if it is red color, we call it hemothorax. If it is whitish in color, we call it chylothorax. If it is pale or clear, transparent in color, we can send it to the lab, and then the lab will tell us is it exudate or a transudate. So this is how, but the fluid appears like that. We'll have a fluid level. So this is how you can see a hemothorax and you can see a pneumothorax. Chylothorax will appear the same, but only when you withdraw this fluid out for a sampling purposes, then you can only say, oh, it is chylothorax. Otherwise, an X-ray which is showing you chylothorax or hemothorax will appear the same. So doctor, the one on the right is not effusion because there is no Menses sign, right? I am not going, Miral, I'm not going into radiological detail. If you want me, I can start a session on that, but that's not of your level. Which intercostal space are we used to aspirate this fluid? So Amru Hajja, I will be coming to the spaces. This question is there. So just wait for that. Right now you just learn what? How a fluid appears on an X-ray chest on a PA view and how air appears on an X-ray chest on a PA view. If you can differentiate these two things, you are perfect. If you can say this is pneumothorax and this is a fluid, it could be effusion, it could be hemothorax, it could be chylothorax. Okay, so when we know the character of this fluid, then we can say it is blood. So on the basis of having blood inside, we call it hemothorax or vice versa. I hope we are clear. Can I proceed to the next? Okay, so now you can see that the diagnosis has been achieved. So pneumothorax, air in the pleural cavity, let's label it. Mediastinum is visible to me, collapsed lung, air, hemothorax, normal side, and we can, remember when we look into X-ray, we always compare the sides. Don't worry for that. Now, what do you see in this X-ray? Arrows has already been marked. I'm waiting for your comments. Guys, collapsed lung, excellent. So, is it air or fluid? Air, very good. So now, I'm showing you a CT scan. What do you see in this CT scan? Shown with this white arrow. Collapsed lung, collapsed lung, collapsed lung, collapsed lung. So this is the same person. CT scan. So this is how you can see a pneumothorax on an X-ray. If there was a fluid, we could have seen a fluid level. But there is, it's all, you can compare the color. Are we good? Perfect. So now, the next question is, what is the difference between the pneumothorax and tension pneumothorax? So now, let's take this concept. Well, it was explained before, but I would like to take it because it's a question where people need to. Pneumothorax, air goes out. Tension, air does not. Excellent, Jude, you are right. So now, let's bring something here. So now look at it. The person is inhaling, air is coming in. When air is, and this person has a pneumothorax, we all know. The lung has collapsed. But with each breath in, the air the person is breathing in because he's a living person. So now, when the air is coming from the nose, through the trachea, reaching to the lungs, so this is going on. And from the wound, air is also entering into this pleural space. So air is coming in, but air is coming in, so that is also occupying this area more and pushing the mediastinal receptor onto the opposite side. I'm not talking about one-way valve right now. So this is air is coming. So now just see what happens. This is inspiration. While this person is exhaling air out, you can see that, the big change. Now, when the air is going out, so now you can see the lung, and look at it, air also goes out. So this is called a pneumothorax, where with each breath, you suck extra air from the atmosphere because there is an open wound. And with each exhalation, air passes out, so in and out. So that will not be compromising, that will not be affecting in a big way to the patient. Patient can survive. Patient has a time to live, but not hours and ages. So Leon is writing. Leon, wait for your comment. So guys, are you clear that pneumothorax, with each breath you may suck air? Guys, now remember one point. Pneumothorax does not mean that we only wait for a wound from outside. Even this, if there is a damage in tracheal tree, air can start leaking from the substance of the lung, and it can start filling in the pleural space. So it's possible from here or here. So with each breath we are taking in into the system and also into the pleural space, and with each exhalation it's going out. So this is called a pneumothorax. Now let's bring what is called tension pneumothorax. Now in tension pneumothorax, all is the same. All is the same. And air may be coming from the wound outside or from the inside, from the lung. You can see both options are there. But now this wound, if I compare it with the previous wound, look at it. This was straight away. They are far away from each other. But situation is different here. There is something which looks to me like a valve. So person is inhaling air, so air is entering, like the previous one, like the pneumothorax. And while this patient is exhaling, now at that time what happens? This valve closes, so no air goes out. This valve closes, so no air goes out. So with each breath, I'm increasing the pressure in this pleural space, and this pressure will cause significant shift. It causes significant deviation onto the healthy side. So it's been pushed away onto the opposite side, and then trachea got shifted, and this heart is being under a big pressure. So that will result into all sort of output and input changes, which we have talked about, cardiac tamponade, another thing. Now this is the situation which is called what we can call it now. This is a tension pneumothorax because wound is a valve-like pattern. So with each breath, the air which has been come in is not going out. So now this we call it as tension pneumothorax. Now this is an emergency. We have to insert a needle. Now where to insert a needle in this situation? You can see that the lung has been collapsed. The best possible way, Kaniz, I'll come back to you, just hold on with your question. So best possible way, we can access from the mid-clavicular line, from the front, second or third intercostal space. So this extra air, the air which was trapped here, that air will escape out. And then this mediastinal structures, heart and everything which has been pushed so far, they will come to back to the normal location, not exactly normal, but not in a tension situation, in a pneumothorax situation. So this inserting a needle, usually from second or third intercostal space, from the front, mid of the clavicle. That is a life-saving procedure. And this is these measurement, these intercostal spaces we are putting up, not the normal lung. This is the condition where we have air already and lung has already been collapsed. So now, Kaniz, if I read your question, doctor, is pneumothorax is enough to just deflate the cavity by just inserting needle to second intercostal space or mid-clavicular line and not to... Kaniz, it depends how much air is inside. If this is the situation, we have to insert a tube because that's the treatment. Are we clear? What if it was mid-axillary? You can put from mid-axillary, there is no problem, but approaching to mid-axillary is more easier, or approaching to the front is more easier. Can we differentiate between them on X-ray? X-ray, do you think you will get that much time to take this patient for an X-ray? You'll see him dying when the moment you will take him to the X-ray table. You don't have time, gentlemen. You have to work hard. Rakan, you don't have time, and this is something which should be done without any delay. There is no time. If we have time, we can go for a CT scan, we can go for so many other things. You just look at the condition of the person. If you remember, in the case I've shown you, the person is turning blue. He's breathless. His respiratory rate and his blood pressure is being dropped. So clinical examination, excellent. Sarah, you're excellent. The clinical examination is enough. You're listening to his chest. Your X-ray tells you, your auscultation tells you everything. And this is what we need to do. I hope we are clear now for pneumothorax and tension pneumothorax. Are we clear? Yes or no? Perfect. Okay, guys. So we are good with this concept. Now, next question is asking, could you please explain the difference between... I'm writing whatsoever has brought to me. I have not changed your words. Basically, what I deduce from this question intercostal spaces. Which intercostal spaces are used for doing thoracosynthesis? Pleural tap. Yes, excellent. Thoracosynthesis or pleural tap are the same procedure. Chest tube insertion, pneumothorax needle, pericardiocentesis. And if it is in the back or mid-clavicular line. Excellent. So this is a very big question. So I'll try to go over each and every concept. So I'll take one by one. So I need some image which can help you to understand better. So the question is what? You are interested to know where we are doing thoracosynthesis or pleural tap, where we are inserting chest tube, and where we are inserting needle for pneumothorax, especially when it is a tension pneumothorax, or you want to decrease, you want to deflate the balloon. So now, we learned that from the front, this is a normal lung. Remember, these images which I'm showing you right now, these are the normal structure. This is not a case of pneumothorax or hemothorax or chylothorax. So this is the normal limit. We learned that the lung extent, because you can see that lung, the lower border of the lung is not straight, it's oblique. So my reference point is this mid of my clavicle. If I draw a line, so mid-clavicular line 6 space, I can find the lower limit of the lung. And the pleura 2 spaces below. That if this is 6, this will be 8. This is a normal lung. This is not in from the back. Look at it. Which line? Mid-scapular line. So there I can see that. So this is 10 and this is 12. And then if I see from the side, this is 8 and this is 10. This is which reference line? Mid-axillary line. Guys, we are talking only with reference to these lines. If I'm talking here, this is not mid-clavicular line. If I'm talking here, it's not mid-clavicular line. So you should be specific which line, what is the lower limit of a normal lung? What is the lower limit of the pleura? From the back, what is the lower limit of the normal lung and what is the lower limit of the normal pleura? What is the lower limit of the normal lung and what is the lower limit of the normal pleura from a lateral view across mid-axillary line, across mid-scapular line, across mid-clavicular line. So we need to be very clear. Some people are in waiting room. I'm sorry, 8 people. Actually, today I forgot to remove this option. So please keep me reminding. I'm sorry, guys, but I'm doing a recording. I'm sure you'll get it. Okay, guys. So you can see that these are the normal organization of my pleura and the lung and the lower extent. But be reminded, the lines, the concept of the line is really important. Okay, so this is what I was talking before. So we have seen across mid-clavicular line, what is the lower limit of the lung? Obviously, visceral pleura goes with the lungs, so 6th and 8th, 8th and 10th, 10th and 12th. There is always difference of 2 intercostal spaces. And are we fine with that? Okay, so this is our reference point. So now I'm talking about, first I'm taking insertion of a chest tube. Chest tube, we use it for pneumothorax. We use it for hemothorax. We use it for pleural effusion. We use it for chylothorax. When there is too much quantity, when there is a large quantity, we always use big size. So what we have done, the patient is lying on his side and we are in the axilla. I'm sure everybody knows this is axilla. And then axilla will go to the mid part. We have calculated the ribs, the intercostal spaces. We know that. I'm sure you have seen the video which has been inserted in my lecture that is explaining this picture furthermore. So now I'm just magnifying it. Now I have defined what? I have defined where my pectoralis major muscle ends. So this red dotted line is the limit where pectoralis muscle pec major is ending. This is where latissimus dorsi is ending. And this is the 5th intercostal space. And this is the base of the axilla. You remember when we talk of axilla, we talk about this, it has an apex and it has a base. So now, in this area, we can access, and 5th intercostal space is the safest area. Guys, this is all about safety. You may find some book is writing 6th space. It's okay. That's not a big problem. But now let's see further into this image. I like to add something more here. And that something is, I have another image for you. Now there you can see, To magnify, this is a safe triangle. There you can see my pec major, you can see my latissimus dorsi, and you can see the base. So this is the location of the fifth intercostal space, where in the mid-axillary line, we have to calculate according to the formula from manubrosternal junction, angle of Louis, keep counting the spaces, and you have to reach. So now if I'm going through that, I can only going through serratus anterior and then intercostal muscles. I'm not going through the pec major. If I'm going through from anterior axillary line, there was a chance I was involving pec major. If I was going from the posterior axillary line, I might be interfering with latissimus dorsi. So here I have minimal stuff. I am going through some muscles, but not all of them. And these are, if they are involved, they will be more affecting. So, but this is the safest area. This is most in practice. Okay, so now that was a place described for insertion of a chest tube. Make it very clear. For insertion of a needle for tension pneumothorax or pneumothorax, we go from the front. We go from the front, mid-clavicular line, second or third intercostal space. And for pleural tap, if there is a small fluid, we preferably go from the back. Now question is why we like to go from the back. I like to go back. Why we want to go from the back? Because this is the lowest limit. Even the lowermost part of my pleura. If I'm going from the front, it is ending at 8th. If I'm going from the side, it is ending at 10th. But here it's going up to right up. You can see that this is my, I will not call it 12th intercostal space, subcostal space, because below there is nothing. So it is ending, it is reaching up to that level. Even if it's a small quantity, I can insert the needle, taking care of precaution of saving the neurovascular bundle which lies under the costal groove. So I can enter in this pleural space and I can withdraw the fluid for usually used for what? Therapeutic purposes. So people use 9th space, 10th space, 11th space. These three spaces are intercostal spaces, and the line which is most commonly used is mid-scapular, mid-scapular line on the back. We may use posterior axillary line, which is close to that, but mostly for your sake, guys, there are so many options, so many variables, but you should follow one policy. So mid-scapular line, posteriorly. So you can say 10th, 11th spaces, it's good for you. So we can insert, and that is for pleural tap. This is for the second or third intercostal space for the tension pneumothorax. And for the chest tube, as I have shown you in my upcoming slide, we are using this safety angle, the safe angle. Why I'm calling it safe? You can see that I'm protecting my pec major, I'm protecting my latissimus dorsi. So all of them has been saved, and this is how we can approach this area. Are we good? Okay, guys. So let's go further. Now this is another important concept, pericardial drainage, where we can do a pericardial drainage or pericardiocentesis. A needle inserted, when we are doing it in cardiac tamponade, a needle inserted in the angle between xiphoid process and the left 7th costal cartilage, I'm not saying space, and directed upwards at an angle of 45. Why we are using that? Because we know that cardiac notch is located close to that, so that we are not going through the pleura. Towards the left shoulder, pass through the central tendon of the diaphragm, and then we are going to the pericardial cavity. And I told you how we can prevent that. We should not be entering into the myocardium. We are connecting an ECG probe, ECG electrode with on top of that needle. So if the needle is touching myocardium, we can find a deflection, and this deflection tells all. I hope we are clear for. We have talked about where we insert the needle for pneumothorax, tension pneumothorax, where we need to insert our needle for chest tube, which place we go, and which place for pleural tap, and where we should be approaching for pericardial drainage. So these things should be followed, and these are the safe areas, and they have their own values. In different books, you may find little bit up and down. Those options are maybe fine, but what I follow is this, and what I usually take from your standard textbooks. Okay, guys. Now this is another question. How can we differentiate between the right and left lung in OSPE? Yeah, it's a very interesting question. Remember, your OSPE exam is online. on exam soft. So it is not like face to face. So it will be, I can think this question will be dealt if it was on real situation, it could have been a little difficult. But here it will not be that difficult because you cannot see the 3D image. You can see a 2D image or maybe 1D image. So let's resolve that. Let's bring a situation for you. So you're looking at a lung. Can you tell me, just looking at this lung, what it should be? So everybody is writing left. Why they are writing left? Because you can see one very obvious feature. Perfect, 2 lobes. Excellent. Somebody was asking me a question. Here I can see very nicely. Where is the lingula located? In the lung, upper lobe or lower lobe? You can see that superior lobe. You can see that this is the lingula. You see, you yourself said this is left lung. Look at it. Posterior border rounded, anterior border sharp, apex looks like an apex, and broad flattened diaphragmatic surface. This is the costal surface. You can see the rib marking. So you can see yourself lingula in the superior lobe. Yes, Leon, you can see that. This is the upper lobe and lower lobe. You want to call it superior inferior, you want to call it upper lower, it's up to you, your choice. So this is what you can see that. This is just the description of the same image of this lung. I hope we are clear. So now you have, all of you, I can see that you have identified very nicely. So be rest assured you will not be facing any trouble while you will be exposed to this question. Now look at this lung. What do you think now? Guess. Maximally you can be wrong, but so people are saying it's right. Why are you saying it's right? Do you have any explanation? You don't see the fissures. You don't see the 3 lobes. Why are you saying this is right? Guys, we talk about it. Posterior border should be rounded. I can see that this is the mediastinal surface. This is the costal surface. This is the apex. This is the base. If I put my hand on that, I keep my thumb on this side. So it is which lung? Right or left? Left. Excellent. No right. Why are you saying right? This is the mediastinal surface. Look at it. This is the costal surface. It's the same lung. Right? Okay. Going further. Now what about this side, this lung? Anterior border which is sharp, apex, base, and posterior border is not shown here. Are we good? So guys, this is very easy and don't worry for this question. Once you'll get it, you will be happy if you find this question there. You can easily do that like you did it here. Okay, what is the lingula? Where the lingula is located, I have shown you. So I need not to bother for that, but I have an image where I can show you. Look at the right lung. Look at the left lung. Look at the heart shadow. The cardiac, the heart is being, I should not say shadow, the heart itself. And look at this cardiac notch. Look at the lingula. And we know that left lung has only upper lobe and lower lobe. So, and I have shown you this lingula is part of the upper lobe. And this is the diaphragm. And this is my left brachiocephalic and right brachiocephalic. They are making joining superior vena cava. And that's going to the right atrium of the heart. These are my internal jugular veins joining with the subclavian. This is the thymus gland. And under this thymus gland, I have the left brachiocephalic, right brachiocephalic. And if I remove this thymus gland, I can show it to you inside thing. This thymus gland usually seen in the early age, then it disappears. And this is the thyroid gland. You can also see that. And this is the internal jugular vein. And these are the subclavian veins. And this is brachiocephalic. Left brachiocephalic, long, oblique. Right brachiocephalic, short. Both of them join to form superior vena cava. If I remove this thymus, you can see them very easily. That's not a rocket science. Now, look at it. Same. You can see the left lung, you can see the right lung, and then you can see the lingula, you can see the cardiac notch. You can see the heart shadow, you can see the diaphragm. And there you can see it's same explanation of the same image. Now, coming to this image, I'm showing you what left lung. We have seen in real pictures the cardiac notch, and we are looking at its different features. I don't see there is any rocket science where we need to be bothered a lot about that. So we have talked about all these features: anterior border short, posterior border rounded. Are we clear? And then you can see these are the different impression. You are expected to be good. And then the how the structures has been organized. I have upcoming slide where I'll be talking about how they are organized in the hilum. Look at this gray thing. That is what? That is the pulmonary ligament. And this is my parietal peritoneum. Oh, sorry, parietal. What parietal? Pleura. And inside that, it will be visceral. And this is the bare area of my lung. Now, look at it, a real one. So, is it right or left? Left. See, you guys are pros. Why we are bothered? Everybody knows it, mashallah. So now we can see that anterior border short, posterior border rounded, apex conically upwards, and base is flat. And we all say left, so we are looking at the lingula. And there you can see how the structures has been organized within the hilum. Guys, I told you the structures, the organization of the structure is quite similar. But when you look into different real images, it gives you a little bit different approach. And I have a small description for you that has been shared with you on the Moodle as well. So now there you can see we all said this is the left. So this area should be occupied by the heart. So heart comes here. And this is, you can see that a big impression is being shown here. That is my arch of aorta. And then it becomes descending aorta or thoracic aorta. And can you see there is a margin here? This area, this small area is for esophagus. Let me make it pointer option. Let's make a pen. So now what you can see here, this area is where my heart should be. This is the cardiac area. And now you can see that. Now you can see that from this heart, I'm having this arch of aorta, which is going down all the way above the hilum. So is it clear now? This is heart, this is arch of aorta, and this is thoracic aorta. And okay. So I'm sure everybody should be clear with this. So now we can match it now. Can we match it now? You can see the stuff. What impression is below the hilum? This one? Actually, this is, you are looking, as I told you, this is not a 3D view. This is the diaphragmatic surface. It's just a little bit impression of, because, the heart comes in between. So this.
The thoracic aorta, it's the descending one. Yeah, dumbass.
Are we good? So if I completed the complete heart shadow, it will be going something like this. Are we good now?
Good.
So make it complete heart. Are we fine? Okay, guys. So let's proceed further. So now, this is my right lung, because you can see 2 fissures and 3 lobes. And then how the structures has been arranged. Here we see what? This is my, let me label it. This should be my superior vena cava. And this should be my azygos, which arches over hilum of the right lung. And this whole thing is the cardiac shadow. Are we clear about this? And now this remaining area, this area is for esophagus. Is it easy or difficult? What is the uppermost structure in the right? So this uppermost structure is my superior vena cava. And then this is the azygos. And we all know azygos vein opens in the superior vena cava. Are we clear? Can you repeat the left lung impression? You lagged. I know my system was saying I was lagging. So now, see it here. I'm doing it again for you. So this whole big area is for the heart. This is arch of the aorta. This becomes descending aorta. And this area is for the esophagus. Are you clear now? Yes, it's enough to say cardiac impression. It's fine. Excellent. There's no need. Guys, don't stress out yourself. It's okay. So now we are good with the right. So let's take on a real heart, a real lung. So now look at it. Is it right or left? We all know by our description that this must be right. So now let's try to find out. This is the hilum. Now let's put the heart first. The heart goes all of this area. So this is the cardiac impression. Are we good with this? We are dealing with the right lung. And then what do we see here? Can you see this small groove going here? Just behind the hilum. It's opening into something big. And that is my superior vena cava. And this is my azygos. And now this remaining area, that is for esophagus. Are we good? Obviously, azygos opens into superior vena cava. Now, let's bring, you can see that all what I was trying to show it to you, it has been shown here. And you can see this is where my heart is. And this is what superior vena cava opens in that. And this is the superior vena cava. And this is my azygos. And this area, all of this area is for esophagus. Are we clear? Good. So I'm sure you people not having any significant problem. Now look at it. The hilum of the right lung. Because we know right lung, the bronchus is short, wide. So it divides before entering. So we can see two openings. And that's why they are differently located. It is slightly higher up. Otherwise this, what is this? Pulmonary artery, as we said, it's always on top and it still is like that. But because of this arrangement, it looks different. It is always on top. And these veins, they are in front and below. So this is a common presentation and you can see the same stuff. This is, look at my bronchus. Are you with me? Look at my bronchus. Look, it has been dividing here. Its upper part and its lower part. Now look at, this is my pulmonary artery. And look at it, my pulmonary veins. And this is a kind of a lymph node. Are we good with that? So let's do the same on the left lung. Left lung, just see where are the things. This is my pulmonary vein. And that's my, because my left trachea, left bronchus is long and narrow. It enters and then divides. And thus in front I have the pulmonary artery and below I have the pulmonary artery. And above I have vein. Guys, they are different because they have oxygenated and deoxygenated business. So is the upper part of the bronchus the uppermost structure is in hilum of the right lung? Yes, no pulmonary. Pulmonary artery is there. You are talking right lung, Jude? This is, we are looking at the left lung. So you have seen the, first confirm your right lung. Right lung, uppermost structure is what? Left pulmonary artery. Below you are looking at the bronchus. And then these are the pulmonary veins. Are we good so far? So I'm saying pulmonary artery. Sarah, you can see this pulmonary artery. Okay, going further. Now in this one, as I told you, it divides and then enters. That's why it appears it is little bit up, but this pulmonary artery is still on top. And then we have this bronchi, and then we have these pulmonary veins. Are we good? Okay, guys. So now let's go further. So what is around each hilum? I mean borders of the hilum. I have just already mentioned. I can show it to you. So could you briefly clarify the arrangements? I have done it. Now I can show you on this upcoming slide. So let's. This is the bare area where we don't have any pleural covering. So now that is the mediastinal surface of the lung, and there is my hilum of the lung. Hilum is the gateway, and then we can see that parietal pleura is this one, the green one, and then it becomes externally, we call it what? We call it pulmonary ligament, and it is also a dead space. Physiology people must have talked about a dead space. Look at it. Something blue has been spreading on the surface of the lung. So this blue thing is what? Parietal pleura reflecting on the lung surface as visceral pleura. And now inside, this part of the lung don't have any pleural covering. So we call it a bare area. And now here you can see that on top, what do we have? Pulmonary artery. Then we have bronchus. Then we have pulmonary veins. This arrangement was shown in the previous image. This is I'm showing you hilum of, it's a conceptual picture. It's not right or left. It's almost the same. So now bronchus, most posterior, pulmonary artery, most superior, and pulmonary veins, one is in front, one is anterior, and one is inferior. So remember this arrangement, and this will be helpful for you. So now this upper part is, we call it root of the lung. So this is the root of the lung, and this is the hilum of the lung. What is root? The structures who are entering. What is the hilum? The door, the gateway. And how the structures are entering. So line of the reflection of the pleura, and the structures are going from outside inside the lung. So this is the root which is entering to the hilum of the lung, towards the lung, and this is towards the mediastinum. Are we clear so far? So guys, we need to read these lines I have brought for you. The left and right lung roots are similar but not identical. So they are the same, but they look little bit different. So they are not the mirror image of each other, but they are similar. There is no major difference. Be reminded that if you stick to the same planning, you will not be losing. In the right lung root, the upper part is occupied by a left pulmonary artery lying within the concavity of arch of aorta. Below is the left bronchus. There are two pulmonary veins, one in front and other one below the bronchus. These structures are enclosed in a sleeve of pleura, continuous below to the pulmonary ligament. So that is for the left. And then when we talk about the right, because the right, the bronchus, it divides and enters. So why this is why we got a difference. And then it says in the right root, the general arrangement of the structure is like that of the left, but the bronchus to the upper lobe and the bronchus branch of the pulmonary artery to the upper lobe originates outside the lung. So they divide before entering the lung. Thus the upper lobe bronchus and its accompanying artery are found above the level of the main bronchus and the pulmonary artery. The arteries lying in front of their respective bronchi. Don't get confused with these words. Simply remember that if you know this line, guys, if you know this line, you don't need to spend your time a lot on that. The left and right lung roots are similar, but not identical. And what was the plan? On top, we talk about there was, what was this? You remember in the hilum of the lung? What I said was, on the top we have pulmonary artery. And then posteriorly we had bronchus. Anteriorly we have pulmonary vein. Inferiorly we have pulmonary vein. If you remember this formula, it's applicable to the both of the lungs and you will not be in trouble. But if you want to invite, there are so many things written, but this is the simplest explanation. Left and right lung roots are similar, but not identical. So there is a little bit change because in the right one, in the left one, there is only one opening. Then this bronchus divides, and the right one, it shows two openings because it is short, so it divides before entering the root of hilum of the lung. That's why we can see a little bit distorted and this appearance if we go back to my image. Lagging. What is no? Clear? Okay. No lag. Thank you. So guys, only focus on this top line. You are done. Don't waste your time. Be smart. Okay now. So we also have the bronchial vessels and autonomic nerves and lymph. We know that. There's no problem. So what should we know about costomedia standard? This is just a space which is present anteriorly towards the anterior border. My this hand is going into costomedia standard recess. If you know this much, enough. You can see it more nicely on a CT image. Now, could you review some angiograms and help us identify the arteries? Yes, that's important. So I'll take over one by one. Now just be patient. Look at it. So guess what do you think? Which artery you are looking at? Right. Excellent. So to magnify it, you can see that. This is my ascending aorta, and you can see on the right side, just look at this pattern. Guys, if you have pattern recognition, you don't have a problem. You can see it's on the right side, and you can see it's giving its marginal branch, and then it's giving its tiny dot branches. Any problem with this? If you find this image and you're asked, what is this? So you can simply write, this is a marginal branch. If somebody asks you, what is this? What you should write for that? And this is if somebody asks you here, this is your right coronary artery. Nobody will be bothered for asking these tiny dot things. But you should be asked, this is the right coronary artery and its branches. I don't see there is any problem. Now what about this one? Any idea? Right or left? Again, another view. You can see that the right coronary giving its branches, they are quite identical. And look at its margin. If somebody asks you, name this artery, so you know it, this is the right marginal branch. If somebody asks you, what is this? You know it, this is the right coronary artery. Are we clear? Any problem with these? Good. You guys are mashallah good. Only you're little bit stressed. I know it happens. Now what about this? Is it the same or difference? First tell me this. Different. Okay, so it is not right. For sure. So now guys, we have to see this. I'm not saying anything. First, let me show you this. So this image is like that. So what are you looking at? So you're looking at the left coronary artery. Where is the left coronary artery? Is being shown nicely. This is the left coronary. And then left coronary artery, it divides into what? It divides into circumflex and it becomes anterior interventricular. And then it gives its one branch. We'll be taking in further picture. So basically the left coronary, it divides into circumflex and anterior interventricular, or LAD. Are we good? So that we should know. Now go further. Now we can see more clearer. Is it right or left? Left. Excellent. You guys are mashallah so good. So now we can see that we are at this level. So there you are looking at what? LAD. You're looking at the circumflex, and then you are looking at its marginal branch. Easy peasy. Okay. Let's go further. Now, what do you see here? Is it right or left? Left. Excellent. So this is left. I told you when it comes, it divides into circumflex. It becomes LAD. And then what this should be? Marginal. So what a rocket science here. Is it easy or difficult? You need any further explanation on this angiograms? Now I'm sure everybody can handle the angiograms. Can you? Okay, guys. Okay, let's proceed. What is the clinical significance of central tendon of the diaphragm? It's an interesting question. Guys, we should identify which is the central tendon. This one or this one or this one. I'm putting A here, B here, C here. Now tell me, which one is the central tendon? B. Mashallah, you guys are good. So what do you think is significant? What is this structure? Inferior vena cava. And what about this structure? Aorta. And what about this structure? Esophagus. So now look at it. So this esophagus, inferior vena cava is present here. So this inferior vena cava, there is no any specific significance as such, but they say the vein, it never collapses, it always remains open. That's it. If you know this much, enough. Don't waste your time yourself. But you should know what level. Aorta, what level? 12. Excellent. Esophagus, what level? 10. And inferior vena cava? 8. Mashallah, you guys are ready for your exam. I don't see any problem. So what is the difference between the auscultation and pulsation area, and when do we use each one? Okay, this is an interesting question. So now I have some images for you. What do you see here? Is it auscultation or pulsation? Palpation. Tell me. Auscultation. Why you call it auscultation? Because you are auscultating with the help of this stethoscope. Agree? And what about this? Auscultation or palpation? Palpation. So we are fine. So we are clear for one thing. Let's go further. Someone, now I have to hear to his heart because he has some problems. So I should know where heart should live. Can I do like this? Am I allowed for this? Do you agree? So let's make it a little complicated. So surface marking, look at it. The borders of the heart, and these are the locations of the valves. So valves are located, we know the 4 valves, they are located here. But when we auscultate them, we don't auscultate them here because sternum is overlying. So we know where is mitral valve best, where is the tricuspid, and where is the, all valves we can know the location. So this is pulmonary and tricuspid and mitral and aortic. So we know what are the location. Originally, where are they present? The word A, P, M, T are self-explanatory. Are we clear? So this is an interesting question. Joe is asking. Oh, that has gone. Doctor, in cardiac tamponade, does the heart increase, decrease, or remain the same size? Jude, when heart will not decrease, but the space for expansion of the heart will decrease, and heart will not receiving enough blood. When it will not be receiving enough blood because it's under pressure, so it cannot accommodate more. So it's been under pressure. So under pressure, it cannot pump out more. So that's why it's been trapped heart. Okay, now. So these are the explanation: who's tricuspid, who's pulmonary, who's mitral, who's. Now I have another image. Look at this guy. Where is his heart? So there you can see the borders of the heart and then the location of different chambers. Let's see further. So these are the surface markings for this person, and these are the location. We know that mitral valve, tricuspid valve, pulmonary, and aortic valve. And where we can auscultate them, so we can auscultate them in these areas. I'm sure I have talked about this, so there is no rocket science here. Are we clear about this? Yes or no? Okay, good. Oh. Okay, guys, let's go further. What about this heart? Is it not beautiful? So let's make it, look at it. So this is the areas where we can listen to a heart, area for the mitral valve, for the tricuspid valve, and for the pulmonary and the aortic valves. And I'm sure everybody is good with these because of how much time I have spent on this concept. Okay, where exactly is the thoracic duct in relation to the vessels, brachiocephalic and subclavian, and its pathway? I heard the recording, but I'm still slightly confused. I really appreciate if you have a question, you should ask. There's no problem in asking. We know the location of the thoracic duct. It starts its journey from cisterna chyli, and then it passes through, it shares an opening, and then you can see it's on the right side. And then it shifts, it moves to the left side. And look at it, this is my internal jugular vein, and this is my subclavian vein. They make my brachiocephalic. So you know this, look at it, this thoracic duct goes all the way. Now from the right it moved to the left, and then it turns and opens at this junction. Junction between internal jugular vein and subclavian vein, which left. So this is left side. Are we clear? So I have some more image for you. So now there you can see very clearly. So this is the beginning. This is the cisterna chyli. It is in the abdomen, and then it's running, and it then look at it. It's opening on the left side, junction between internal jugular vein and left subclavian vein, and this is where it opens. The right side it opens separately. So if I look at the distribution in the body, this whole is left, and this one is only right. So this is how the fate of the thoracic duct. Are we clear? Okay, now I can't understand the cardiac plexus. Could you re-explain it? Cardiac plexus, primarily it's an autonomic system. We have parasympathetic and sympathetic component of this. So do we just say that the right side is drained by right hepatic duct? Yes, excellent. So now, to start with my journey, the heart, SA node, we know about this, AV node, we know about that. These are my sympathetic chain. I'm not going in details of those. And from there, these are my right and left vagus. So now, vagus and recurrent laryngeal nerve, through their cardiac branches, they give parasympathetic. What they give? They give parasympathetic. So cardiac branches of the right and left vagus are visible to you. And then you can see the cardiac branches from the sympathetic chain. So they are bringing sympathetic supply. And they are making what? They are making a plexus. So they are doing what? They are making a plexus. And this plexus, we call it these cardiac nerves. And they are located here. And this union of this sympathetic and parasympathetic derived from their respective sources, and they are making our cardiac plexus. And we have two, one is superficial and one is deep. And they are responsible to control all the rhythmicities and all those things. And from here, SA node and AV node, their system and bundle of his and whole cardiac conduction process is being carried out. Are we clear now? Somebody is stuck with that, Yusuf. So no esophageal impression on the left lung. My dear, on the left lung we have very small impression. Go back, you will find it. Should we know when exactly is the superficial plexus? No need for going those details. Just simply know who makes superficial and deep cardiac plexus and what they do. If you know this functional part, enough. You're not supposed to go a PhD on these things. Okay, so what attached to every part of mediastinum, because some of them, they exist, for example, in superior mediastinum, but we don't know if it descends with it or not. I don't understand this question. Can somebody help me to understand this question? So Dima is asking, phrenic gives sensory sensation to pericardium. Yes, Dima, you are right. Doctor, does the esophagus normally deviates? Yes, it deviates, Malak. It's not straight. Can somebody help me with this question? I tried myself, but I couldn't find what this person is asking. So Jude is helping me. I think that he means what structure descend from the superior mediastinum to the inferior mediastinum. Nothing descends, is all tubes are going up and down. That's it. Anyways, this person can meet me, but now Sunday is the exam. Like the friend. No, there is no such thing. Don't waste your time for that. Okay, guys. So how do we know if the fluid is not and we use just tube from an X-ray? Malik, I have explained good time on that. So you need to now. If I continue answering this question again and again, if I have time left, then I will go over, because I have a lot where I'll be talking about sectional anatomy, and for that you need coffee. What does an inflammation of azygos constrict? What does an inflammation of azygos constrict? Azygos is a blood vessel. It's not esophagus. Inflammation, the venous inflammation, if veins goes inflamed, they got thrombosed. The vascular diseases are different. Yes, but it can dilate. It depends on how much is the involvement of the valve involvement, the wall thickness and all those parameters. Veins dilate when there is more pressure of the blood is being received by them. They dilate at that time. Okay, guys. So which recurrent laryngeal nerve, when compressed, cause hoarseness of? Okay, let's talk a little bit about recurrent laryngeal nerve. Guys, this is the aortic arches. And we all know, Paul has explained, spent good time with you, that these arches, they don't persist, all of them. Most of them disappears. Only on the right side, they survive, and on the left side, they survive. So because of that, the recurrent laryngeal nerve, it's stuck with this arch of aorta, and then the rectus arteriosus is there, so it stays here, and the right one goes under the subclavian, because there's nobody who's, so this arch is not there, so it ascends up. Now, looking further, this image, so you're looking at the left, you're looking at the right. So this is how it persists. So I'm sure these diagrams has been shared with you. So now if I go back to the question, recurrent laryngeal nerve, no matter right or left. The question is what? So try to understand what is the question. Question says, which recurrent laryngeal nerve, when compressed, cause hoarseness? Recurrent laryngeal nerve, if involved, no matter right or left, if involved, it will cause hoarseness. So don't say only left is left. You are learning this area. That's why. But if right is also compressed, if right is also have a problem, if right is also have an injury, we have hoarseness of the sound. So it is for both of the right and left. Both of them can be involved. That's not a problem. Both of them can give us. So we have revisited this concept. Now, can we go over the sectional anatomy? Yes, we can. But now I need to have a sip of water because I have to speak a lot more. Can you discuss about Horner syndrome? Kanis Fatma, if time allows me, I will do that, because I will see. Don't worry. Yes, doctor, speak a lot about sectional anatomy, please. Yes, Faris, I'm doing that. I'm ready for that. I'm missing my coffee because I came right from uni and I was just engaged with this. So guys, sectional anatomy, there's a lot there. How we understand, there are different views, different things. So let's start. What is happening? We are sectioning somebody at here. We are cutting someone at this level. When we cut, we get an image like that. Now what I know from this image. So let's try to figure it out. This looks to me a vertebrae. This looks to me at the head of the humerus. This looks to me to the coracoid process. So where we should be engaged with that. We are not bothered with these structures. Ignore this. Ignore this. We are bothered only in this area, because we are in CVP. So ignore all of this. So just stay here. So what we see in this, let me make it a more simplified image for you. Okay, there you go. So my main focus is here. Now my question says, can I see? This is the vertebral body. What do you think this structure should be? Right? Trachea, excellent. So you guys are mashallah good. Trachea. So this is my trachea. And what's behind the trachea? This structure should be. Esophagus. Great. You are able to identify this much. Your pros. Rest. And then what do you think these structures could be? These could be my carotids. Excellent. If I figure out, I can find my veins. You can match, mix and match. Okay, let's go down. So these, I have only mentioned about those numbers which I think are related to us. There were so many numbers. So guys, when you find these type, I have shared with you some of these images, and you see the numbers are up to 32, and I have selected what 3 and 3, 6 and 2, 8. So 8 are concerned with you. Rest, forget it. Not today. Okay, now my section level is a little bit down. So now I'm seeing something. What do you think is this? Trachea. See? And now what is additional coming up here? Lung. Excellent. And what do you think this structure should be? Going to my vertebrae. Ribs. So, and then these small tiny tubes, no one is bothered. You should be bothered for esophagus, you should be bothered for trachea, you should be bothered for lung fields. So, if you see in a schematic picture, you are fine. You survived very well. You picked up so nicely. Okay, let's go further down. Section is, my sectional, this red line is going down and down. So we can see more lungs. We can see trachea. We can see esophagus. And we are seeing more of the structures which are related to us. So now, are we good with these? So there is my, what is this? Match it here. Think. Yeah, you are fine. And what these should be? These blue things. Perfect. You guys are pros. I'm really impressed. MashaAllah. So now my sectional level is going further down. Now what do you see a lot? I'm sure everybody knows what are these. And now we are looking at the sternum. You're looking at lung field is getting more. Ribs are quite visible. And then we know what are these tubes, and what are these structures. So my heart starts appearing up, but not complete yet. So now let's see in this image, there you can see the tube starts coming up. Are we good? Perfect. Now, let's go further. Sectional level is down. Now, wow. I can see something very nice going all the way here. I can see something rounded here on the right side. I can see something rounded with a thick wall. And I can see a muscular tube. And I can see the lungs. So, people are saying arch, excellent. People are saying superior vena cava, excellent. People are able to identify trachea, excellent. Esophagus. Are we required to identify the vertebral levels? Lean, don't kill people. Relax, it's COVID time. So guys, if you are able to identify these things, you are pros. Are we fine? I can see, mashallah, most of you are able to work connected. Okay, let's go a little bit down. So now, I can see from arch of aorta, I'm getting things more prominent. And I'm getting 2 openings. And my vein is there. So ascending and descending, excellent. And the rest is the lungs and all that. See, you guys are mashallah. And look at it. What happened to my trachea? Can you see it's branching? Can you see it's branching? So now I'm at a carina level. Excellent. So we can see that it's very nicely showing you the same image. But this one is still in process. But you can see very nicely, you're looking at the ascending and the descending aorta and superior vena cava. Okay. Go down. Now things are Very clearer. We all know who's ascending and who's descending. Look at it, two bronchi. There's no more trachea. Look at this vena cava thing, and we are now entering the heart. So we are making some more structures which are more visible to us. Look at it. Pulmonary trunk starts showing up here. Are we good? You're looking at the ascending and descending aorta. You're looking at what? What is this? Superior vena cava. Excellent. Okay. Add further lower down. Now things are more clearer. Where is the esophagus? Yes. There you go. This is the esophagus. Look at it. This is the esophagus. And what about this? Esophagus vein is coming up now. This is the esophagus. And you can see things. And you can see my heart is now getting more established. And lung is almost covered. Anterior border. We always say anterior border is sharp, posterior border is rounded. You can see it. Sharp anterior border, rounded posterior border, costal surface, mediastinal surface. Are we good with this? So at lower level, now my heart is very established now. And things are, I'm sure everybody is pro now. So you can see that my chambers are starting showing up different details. Are you connected to me, guys? So you can see now chambers are very clear. But still, like can you see these valves start appearing in the aorta? Now at lower level. Now it's well established. Heart is well established here. So I can see very clearly what is on the right side and what is on the left side. I can admit this. Do we need to differentiate between chambers on the heart? Yes, you have to be. But we will not be challenging in a difficult way. You are descending aorta. So now section is at the lower level. So now no more ascending aorta. You are seeing thoracic aorta. And there you can see now thick wall, left and the right ventricle, left and right ventricles and atrias. And you can see now something else is being showing up. Now at this level, what happened now? Liver has come, inferior vena cava, thoracic aorta, and now shortly it will become abdominal aorta and lungs. Heart is gone. End of the story. Is it easy or difficult? How we can differentiate between the chambers? I have upcoming pictures. They will be more helpful. So now we took a heart and we section it at level A, B, C, D, E, F. Guys, I share this thing with you. You already have it. And these are the different sections. I can show you how we can see these sections now. So this is level A. We can see here, lung is visible, trachea is visible. Are we good? Now, we can see T4 level, esophagus is there, brachiocephalic, right and left, and then right and left lungs are visible to you. So level C, look at the pulmonary trunk, ascending aorta, descending aorta, superior vena cava. Everything which we have just seen now, it's getting evident. Now when I go down, I can see now things, ascending aorta, even valves, if you focus in this picture, pulmonary trunk, they are emerging. So when I see this level, left atrium is very nicely visible. Right atrium, pulmonary infundibulum, and these are the carotid, the cardiac, aortic valves are emerging. Now you can see the interventricular septum, right ventricle, behind the sternum, always right ventricle, right atria, left ventricle. Look at the thickness of the wall, and look at it is thin. And this is the left, this is the right. So if somebody asks me this structure, if I don't know, I can say this is esophagus. Now, this is more explanatory. So we are at what level? Let me drag it a little bit. Okay, now we started seeing so you can see that the trachea has been shown up and the esophagus has been shown up, some of the vessels. So now things are getting clearer. Esophagus, trachea, You can see the from arch of aorta, we have on the right side brachiocephalic trunk, left common carotid, left subclavian. Look at it. Brachiocephalics. Left brachiocephalic crosses. This is the right brachiocephalic. It joins with that. Little bit down, we will find superior vena cava. Now look at it. Arch of aorta. You can see very clearly. Superior vena cava has been formed. Trachea has been formed. Esophagus is shown up. Look at the lungs. Going down, I'm sure everybody understand. Ascending, descending, superior vena cava, pulmonary trunk. Go further. Now the chambers start making. Where the trachea has gone. So now I don't see the trachea because I'm at T7, T8 level. I can see very nice left ventricle, right atrium, left atrium, esophagus, my aorta. Look at it. Liver starts showing up in this image. Aorta has been there. Esophagus is there. Everybody can say now this is left ventricle, right ventricle, and then this is what? Behind the right ventricle, what should be there? Right atrium. And the left one has to be squeezed out. I'm sure everybody is clear. Stomach is showing up. So we are going down and down. Liver is quite visible. Inferior vena cava is being showing up. Are we fine? So, guys, now in the last, I'm concluding the session. In the last, there is a small practice for you. I have brought a section. We spent good time. So just, this is not a test. This is just to see how you people perform, what you have learned. Okay. So now what is the structure? Guess. Aorta. Excellent. What is this? Green thing. Esophagus. Perfect. What is this? The pin has dropped where? Where I have dropped the pin? Right atrium, right atrium. MashaAllah. Where is the pin now? Right ventricles, right ventricle, right ventricle. And where is the pin now? Left ventricle. So guys, with this note, I wish you success. MashaAllah, I am impressed. You guys are doing very good. And if you continue, I will see you passing with the flying colors, and I'm sure all you are here, you deserve to have A+. That's my ranking for you. And just take care of yourself. Just focus on the major thing. Don't waste your time. Don't go into fine details. If you have 2 more years left to finish this CVP, then you have to go in those details. But focus on major structure where we have been emphasizing you. And I'm really impressed by the performance of your class, and I'm looking forward with nice doctors which are coming for our tomorrow. Thank you very much. Take care.